Hi there, it's Rob Arntfield speaking to you again, and this module will focus on point of care transesophageal echocardiography, an area of great excitement for me and many others as we realize that TEE at the point of care may just revolutionize the way echo is done in acute care environments. In this module, we're going to focus on a comparison of TTE to TEE briefly. We'll talk a little bit about the questions that we can ask with point of care TE, some logistical aspects of getting started. We'll discuss safety a little bit. We'll talk about training methods, a starting point for a TE protocol, and we will close with some case examples. Transthoracic echo is most familiar to all of us at the point of care. Why? Well, it's non-invasive, so it was easy to learn. We could learn on our friends or at weekend courses quite easily and readily apply it at the bedside. The problem is many of our sick patients have factors that get in the way of quality images being produced. They may be obese, they may have subcutaneous emphysema, they may not be able to change their positioning to lay on their left side, or they may be ventilated, all too common in the operating room, trauma bay, or in the ICU. By comparison, transesophageal echo really has little in the way of those problems or impediments. There is actually very little user dependence because the probe itself is kind of locked into the GI tract and you can only get so far away from the heart when imaging with this transducer. Things like patient positioning, size, dressings, positive pressure ventilation, all those things really are of little consequence to the image quality. However, of course, the big rub with TEE is that it is minimally invasive. And so we cannot readily learn this or practice this at weekend courses. And so training is slightly more complicated. And if I can be honest, I think also the optics of TE are that it is only a tool of great complexity and should not be used for basic questions. And of course, we are changing this view on TE that it is in fact an excellent tool for the most basic questions we have, because some of the most basic questions we have at the point of care, such as is the heart beating or is left ventricular failure present, is so important to be able to address, and transthoracic echo does fail us far too often. So in looking at the last two images we showed side by side, obtained by the same expert sonographer only minutes apart in the same patient, we see on the left an apical four-chamber view from the transthoracic approach, and on the right a TE image in the mid-esophageal four-chamber. Now, these views are largely equivalent in terms of the anatomy they portray and the questions they can answer. However, one can readily identify that the TE image is flawless for the most part, and the TTE image is barely acceptable in terms of its image quality. So what scope should we be using for point of care TEE? After all, the cardiologists use a 28 view exam. The perioperative cardiac surgical exam is extremely rigorous and detailed as well. Both the cardiologist and the cardiac anesthesiologist, however, are using TE for a very different purpose than the frontline clinician who is resuscitating their patient. In the echo lab or in the operating room, durable, lasting consequences of diagnosis or surgical plans are being made based around complex, multi-dimension, sometimes 3D TE views, whereas again, our scope at the point of care is often very goal-directed and focused on resuscitative themes, as we will review shortly. However, it's fair to say that at the point of care, we've used somewhere between 4 and 11 views rather than 28 views, which might be used in the other environments. And when you think about the scope of echocardiography at the point of care, we must reflect on this scope here, which is really the foundation of point of care echo, as we will discuss again momentarily. But the assessment of LV function, RV size and function, volume status, and pericardium really forms the bedrock of what all acute care clinicians we would hope could do with echocardiography. And this scope, of course, is not my own creation. It is derived from the consensus statements from the American College of Emergency Physicians in 2010, as well as a worldwide critical care document produced in 2009 that really articulate that RV, LV, pericardium, IVC should really be in the wheelhouse of just about anyone looking after sick patients. So it stands to reason that that scope should be what is our initial starting point for TEE. After all, using TE should not change anyone's ability to do echo to be more complex, it should really serve as a adjunctive tool to satisfy that same standard of care. Of course, TE can be ratcheted up and scaled up in its complexity to levels that TTE cannot. But as I've said, I really think the value of this tool is for when TTE cannot satisfy our clinical questions, being TTE cannot answer our clinical questions. So how do you get started with TEE? Well, firstly, you need a transducer. These transducers are more expensive than surface transducers, and so that will vary by your resources. I found great success with simply asking for it, and oddly, sometimes when you ask for things, you get them. So don't count yourself out yet. Put it on your quote for your next machine and see if you can get one. As soon as you get approved for one, I suggest you talk to your cleaning folks in your hospital and identify the workflow for cleaning the transducer. This has caused a number of hang-ups for people I know, including myself, who were able to get a probe but took a long time to be able to sort out a cleaning method. Training and credentialing will vary by center, but one of my recommendations is that credentialing, if it's done for cardiac ultrasound, should not be speciated between transthoracic or transesophageal methods and should simply be labeled cardiac ultrasound, with the spirit being that the standard of care is to do to produce an image of the heart that can allow you to answer essential clinical questions, as we have outlined already, and whether you obtain it from a transthoracic or a transesophageal approach is immaterial. Politics, well, politics are politics, but ultimately this will be, again, a local issue for you, but you must be aware of how your specialists in your hospital who use TE regularly feel about your use of it. You needn't necessarily be beholden to how they feel about it, but it will influence the ease, I think, in which you will be able to introduce this tool, and my general advice is to include them in some discussions early on. You needn't necessarily ask them for permission, but identify how you plan to use the tool. And I think using some of the terminology like resuscitative TEE and clarifying that you have no interest likely in using the tool for a sophisticated diagnostic scope, but merely to meet the standard of care of assessing the LV, RV, pericardium, valves, and IVC that you currently do will put their minds at ease. And your local culture, of course, will also influence how readily you can apply this, and that includes the enthusiasm of your colleagues towards you taking up this tool. Looking at the transducer itself, it's obviously a foreign concept to many of us who use surface probes, but ultimately the transducer has the piezoelectric element. The crystals, so to speak, are in the far end of the scope, and the ability to control how that beam is used are all up here on the handle. And on the handle we see here a small buttons that control the multi-beam angle, which is equivalent to rotating the transducer in a surface approach. Two wheels, one of which operates the anti-flexion and retroflexion of the scope, and one which laterally flexes the probe, and a lock which we will not discuss. With respect to inserting the transducer, there is a disproportionate amount of anxiety regarding this step, and I say disproportionate because it is not justified in the literature from what I can tell. In 30,000 studies collated from 4 different observational trials, there was 1 death related to probe insertion and 4 esophageal perforations. Most of these studies were done in awake patients under conscious sedation, unlike in the emergency department, OR, or ICU environment, where typically our patients receiving TE are intubated and deeply sedated. So I can say confidently that TE is a safe procedure, especially compared to most of the procedures that we do on a regular basis in the resuscitative setting. Training methods, it's very important to find a method to train, of course, and most people will rely on some combination of these, including the use of high-fidelity simulators, courses being offered by medical societies or universities with expertise in TE, and then accessing your cardiac operating rooms that are near you or your echo labs where TE is used can be invaluable, because you not only access the tool itself, but you may access some mentorship and coaching, which is all too valuable when taking on a new technique. In the emergency department, our group has written a couple articles about early training of emergency physicians. We did demonstrate that an afternoon workshop in TEE using high fidelity simulators was sufficient to train 12 emergency physicians to learn and apply a 4-view protocol. After 6 weeks of a cooling off period, people were still able to demonstrate this 4-view protocol on the simulators, suggesting that 4 hours is sufficient for people who are already knowledgeable in TTE. We then followed that up with following the same clinicians over the next 2 years in their application of TEE in the clinical setting. And though the numbers were small, the TE examination seemed to generate a lot of management changes in patients who presented with critical illness and produce a number of diagnostic changes as well. And these articles will be available for you in the module notes on the web page for you to look at. A terrific review article by Paul Mayo and his group regarding the critical care TE examination endorses the French hemodynamic protocol, which is an 11-view approach to the ICU setting. Again, this is a slightly more complex approach to hemodynamics, and as I will go on to say, I think it is quite reasonable for all people to start with a 4-view approach and then scale up based on the nature of your clinical questions in your individual environment. But this is an excellent reference, and I will also include this in the references for you. Simulation training has been recently studied and shown that from an earlier paper that demonstrated French intensivists took 31 in vivo studies to learn TE successfully. Using simulation, they were able to reduce that number of studies from 31 to 13. So simulation has shown across many specialties with TE to dramatically shorten the learning curve once you get into imaging real patients. So there's little doubt that a simulator should be part of your plans if you plan to take up this tool. So if you are taking up this tool, I suggest a lean, goal-directed protocol, the 4-view protocol I've spoken of already. It's been vetted in the emergency department. It can be used anywhere where critical ill patients or resuscitation is taking place, and is a transferable skill from your interpretation knowledge of TTE. The 4 views that I propose and have been published on is the mid-esophageal 4-chamber view, mid-esophageal long axis, the mid-esophageal bicaval or SVC view, and a transgastric short axis view. Why were these views chosen? Well, they replicate quite well the scope of the basic resuscitative echo I've already outlined to you. That is the assessment of the left ventricle, the assessment of the right ventricle, the assessment of her volume status, and the assessment of the pericardium. And as you grow in your complexity of echocardiography, you will graduate beyond these views. But until that happens, if that is your scope, these are your views. And these views are also reasonably analogous to some transthoracic views that you may already know, making that transfer of knowledge all the easier. Let's unpack these 4 views now. So the first view to look at is the mid-esophageal 4-chamber view. And this view is ideal because it is actually the default view that you get when you insert the probe into the esophagus, and no real probe manipulation is required. The 4-chamber view features the left atrium, the mitral valve, the left ventricle, the right ventricle, the tricuspid valve, and the right atrium, and the hyperechoic pericardium surrounding it. This view can be used to address a number of clinical questions, of course, including the LV function, RV function, pericardial effusion, a gross assessment of the valves, and is used in cardiac arrest as well, as we'll show you shortly. The all TE images feature a numeric display here, which is the setting that the omniplane or ultrasound beam angle is set at, currently 1 degree. Really is the same as 0 degrees, which means no manipulation has taken place. And we'll see in subsequent images how this is manipulated to generate different views. The mid-esophageal long axis view is analogous to the peristernal long axis view. And if you're familiar with that view, you'll recognize a lot of the structures and maybe even agree with me that this looks a lot the same, just flipped around. You have the RVOT here. You have the left ventricle. You have the left atrium, the mitral valve, the aortic valve, the ascending aorta, and you also have a pericardium, and the hyperechoic rind around the heart can be seen there. And of course, this view is excellent for LV function, assessment of valves, and for pericardium. And now you'll note that this view is obtained at 120 degrees, which is a broad range for the midesophageal long axis, somewhere between 120 and 140 degrees. If you're confused about this whole degrees thing, a simulator or a 3D depiction will help, but ultimately think of the prescribed number here to be very similar to when people tell you where to place the index mark for surface echo. Of course, we don't have an index mark for TEE, so this is our index mark. So when someone says point the dot at the right shoulder to get a parasternal long, that's the same as me saying go to your 120 degrees to get a midesophageal long. You kind of commit it to memory, and as you develop spatial orientation to the modality, you understand why this number or why that direction makes sense. But ultimately, it's because the probe handle and the transducer head are separated that we have to use this highly prescriptive approach with numbers. The midesophageal bicaval view is our next and third of 4 views. This view, of course, replicates the IVC view to some extent, allowing us to make determinations of volume status. Now, again, this is most typically used in ventilated patients where the SVC is an intrathoracic structure and will therefore compress upon tidal ventilation in a positive pressure setting. And so this is the SVC here, the right atrium, and a bit of the IVC can be seen here. And the left atrium, like most midesophageal views, forms the near field and the acoustic window from which we look through. The intraatrial septum is seen here. So again, this is great for volume status, but it can also be used for guiding procedures like guide wires from the central lines inserted can be seen sometimes coming through the SVC there during resuscitation. Our crystals are set to between 90 and 110 degrees, and here we're at 106 degrees in order to get the bicaval view. The last view on our list, 4 of 4, is the transgastric short axis, where the probe is advanced into the stomach, anti-flexed a little bit, and the crystals are at 0 degrees. This generates a short axis plane. Again, we like the papillary muscle level, just like in transthoracic, we see the posterolateral anteromedian papillary muscles here, and we see the pericardium here. The RV is off to the side, and we have a nice, easy representation of global LV function here. And yes, I know what some of you are thinking. This LV is not beating terribly well, with pretty hypokinetic region here and nearly akinetic region here in the anterior wall. Remembering, of course, we're shooting from behind the heart, so this is the anterior wall and this is the inferior wall, which is reversed from the transthoracic image you're probably more familiar with. So let's close with some case examples using these views that we've just shown. First case, a bread and butter point of care echo case, is the exclusion of hemopericardium in trauma, where a patient will come in, of course, stabbed or shot, and of course they have subcutaneous emphysema because they've been injured through the thorax. Imaging is difficult from a surface approach. The stakes are very high, of course, so a TE probe is inserted to exclude hemopericardium. And here is a short axis plane. We see a hyperdynamic ventricle with near end systolic obliteration of the LV cavity. But our main question, of course, is there a large pericardial effusion or any pericardial effusion to really support the idea that there's been a penetrating chest injury or cardiac injury? And thankfully, there is not. This, of course, is easily interpreted by you because you already know how to look for a pericardial effusion from your previous transthoracic echo exposure. Case number 2 is a patient who was brought in cardiac arrest, received very short resuscitation with some volume loading with crystalloid and some epinephrine, had return of circulation. Transthoracic images were challenging, and so a probe was inserted, and we see the transgastric short axis view here and the midesophageal 4-chamber view here. So what is the striking finding? Why did this patient arrest until proven otherwise? Well, of course, most of you have seen the anechoic fluid layer surrounding the heart, quite large here in the transgastric short axis perspective. So this patient had an arrest due to tamponade until proven otherwise when presenting with an effusion of this size. Again, a readily identifiable pathology from your previous transthoracic exposure. This patient presented with shock and respiratory failure requiring emergent intubation. A TE transducer was inserted on spec due to anticipated difficulty with transthoracic. The patient had a relatively reassuring looking mid-esophageal 4-chamber view. The provider then went to 138 degrees, as it turns out here. And so what view does this generate? Well, of course, this is the mid-esophageal long axis view with the left atrium, the left ventricle, the RVOT, mitral valve, and the aortic valve. What is the striking abnormality here? Of course, it is the aortic valve. We see thickened leaflets and a mobile density attached to, I expect it looks like the left coronary cusp of the aortic valve, consistent with endocarditis, consistent with total aortic valve failure, and our wide pulse pressure shock and fever, easily identified on this high quality TE image. Lastly, not all our images are quite as high quality, but man, they do the job in the most difficult of circumstances, including this case of intra-arrest TEE, a commonly espoused and growing application of TE in resuscitation. Here we see a mid-esophageal 4-chamber view, sort of tilted on its side a little bit. I'll identify the structures for you: the left atrium, the left ventricle, and the just off screen left there, the right ventricle, and the right atrium. We can note the motion from CPR occurring in the far field here as CPR comes in and out. And the striking abnormality here, well, there's lots going on, but ultimately you can see these bubbles, that's just saline, but in amidst those bubbles you can see these larger densities of isoechoic or even almost hyperechoic in parts, mobile structures through the right side, which is consistent with a clot in transit in this 40-something-year-old who was previously well. So immediately this changes the ACLS approach and triggers the prescription of some thrombolytics. And of note, this diagnosis of PE causing cardiac arrest was obtained without stopping CPR at all. So unlike transthoracic, where pulse checks typically require the cessation of CPR to look at the heart with the probe, we can do everything in simultaneous nature with TEE, which is excellent. So that's it for this screencast. I hope I've shown you some of the merits of point-of-care TEE, and I'll just summarize a few of the key points now. So resuscitative TE is happening at the point of care, not just at my center, but at many centers around North America, both in the emergency department and the ICU, and expanding scope among the ORs as well to non-cardiac anesthesiologists. Of course, TE generates superior image quality to TTE, and that's of growing interest to those of us who make hard decisions at the point of care for shocked patients. Logistics and training are a little more complicated than agreeing that TE is great, and so conquering those will require some local understanding of the forces that govern both the budget to acquire a transducer and the training methods that will work for you and your group. With the training methods in mind, those simulators are invaluable, and I suggest that you discuss simulator acquisition if you don't already have one. Discuss it with the other groups in your hospital who might have an interest in training their fellows or staff in TE. When getting started, a basic 4-view approach will probably get you going no matter who you are, and you can ratchet it up from there. But those 4 views that we discussed, the mid-esophageal 4-chamber, mid-esophageal long axis, mid-esophageal bicaval view, and transgastric short axis will get you off the ground and will allow you to achieve the standard of care we discussed, that is the assessment of the LV, RV, pericardium, and IVC. TE is safe, and that is an extremely important message to carry forward. The data does not support this as being a dangerous procedure at all, and in fact should really just be put to rest. And good news for those of you with transthoracic echo training is that the interpretation of this tool is readily available to your brain already because you've done extensive exposure to TTE, and so that skill is already locked and ready for you to apply. So I hope that you've enjoyed this screencast on transesophageal echocardiography at the point of care. You can join me for other echo-related screencasts on the Institute, and you can check out the references in the show notes. Thanks for listening, and we'll talk to you again.